Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today, I'm delighted to be joined by Lisa Bari. She is the interim CEO for the Strategic Health Information Exchange Collaborative. Lisa, thanks for joining me today.
Yeah, thanks, Nick.
So I always start off because I think everybody has fascinating backgrounds, yours equally so. Tell us a little bit about your history and how you arrived at this role in this organization.
Yeah, absolutely. So I first joined healthcare back in the Bay Area, where I'm from. I worked for many years in digital marketing and data-driven marketing, and ended up as the executive head of marketing at Practice Fusion, the now infamous Electronic Health Information Exchange, EHR rather, said exchange too soon, for mostly primary care, independent primary care practices. And I left Practice Fusion, very, very interested in health policy and less interested in staying in the sort of startup landscape of the Bay Area at the time. And then I went back to school as the oldest graduate student and got a health policy degree from Harvard, and then realized that I really wanted to do more in the policy world. So I ended up at the CMS Innovation Center, which runs all of the value-based care models for CMS, where I ran health IT and interoperability policy for first the Comprehensive Primary Care Plus model, which at the time was the largest test of primary care payment and delivery system reform in the country, and moved on to sort of advising the entire center and parts of CMS on health IT and interoperability policy. And in that role, I co-wrote the CMS patient access and interoperability rule with many other talented folks and contributed from the CMI perspective, and then left to do my own thing. And through that, ended up in this interim CEO role at SHIEC, which is the Strategic Health Information Exchange Collaborative, the organization representing 81 different HIEs across the country, to other folks, to states, the federal government, and other partners. So in this role, I've been able to really work on expanding the visibility of the work that HIEs are doing across the country.
Fantastic. I mean, there's so many things within there. So first of all, you were in the Bay Area and you left. There's some people that would question that decision. So there must be something behind that.
Definitely working at CMS. You got to be here in Baltimore.
Interesting that's, and you're still here, right? That's it's a permanent move.
Yeah. I also had family ties to Baltimore and to Maryland, so it wasn't a huge stretch for me. But definitely, if you want to be close to the work that's happening around Medicare and Medicaid, it really is helpful to be in the broader DC area.
Good to know. I think, for those people that are interested in those kind of areas, I think that's an important thing to actually understand. But then, before we get into SHIEC and, some of the work there, I want to ask you about the interoperability rule, if you were part of that whole thing. And I've got to say, as an external person, looking at this, my question really is, why has this just not been a mandate from the very outset? Why is it feels like this bolt on, it's like security. Oh, we'll deal with security. Why did it take so long, do you think? I know you may not know fully, but I'm interested to understand why.
Well, beyond just that, I am, a scholar of health policy to some extent. And so I can tell you that with government policies, with public policies, it really is a question of creating, the right, or finding the right policy landscape and finding sort of the open window. Once you do something, people realize it can be done. And that is really important in health policy in the US. When you look at something like the Affordable Care Act, which led to so many of these things, including the CMS Innovation Center, including obviously healthcare.gov, once it happens, then it expands people's minds as to what is possible. And I think that with these interoperability rules, so many of us have been talking about, well, we just need to mandate, we have to make it happen, but you need enough people in states, enough health IT vendors, enough HIEs, enough healthcare providers to start to get to the same place before you can really successfully mandate, in air quotes, mandate something. The time has to be right. The landscape has to be right. And so we got past that hurdle. We got to the place where enough people were saying, this has to happen. It's time for this to happen. And that creates the opening for new policies, new laws, new regulations that actually get us, closer towards interoperability. And now, just a couple of years later, we're looking back on the interoperability and patient access final rule and saying, it didn't go far enough. Do more. And that's great. That's actually how policy works, right? And so I think it's really about, in the best case scenario, that's how policy works. That's really the best case scenario. So I think that, I think it's really, I think it's great and a great sign that people are asking for more now, because that means we got it right. We didn't go far enough and there's more to do, but that's good. We're moving down the path now.
So I think that's really interesting. If I was to tease out of that, the incremental steps or the inflection point is you have to have critical mass to affect a let's call it significant policy change. Is that a fair sort of assessment?
100%. I mean, I think in particular in healthcare, in particular in the US, I think there's so much decentralization. There's so much that is left to the states. There's so much that, the private sector has control of. So you really need to get to critical mass. I think this is a particular political ideology to wait until the private sector has started to do something or also started to create sort of standards and guidelines. But I think it's actually pretty effective, right? You look at something like the Karen Alliance, who are trying to create these rules of the road for apps. That needs to happen from that group. And it is going to be better if it feels like it's coming from the bottom up versus from the top down. And so, again, I'm not trying to get into the complexities of political ideologies of libertarianism or whatever, but ultimately when you have, this decentralized system that we have, it's really important that things do come from the bottom up versus the top down to really, get a foothold. And so I think that's what you see with the interoperability and patient access final rule, and also with the Cures Act rule and things that are coming after that. There is a little bit of mandating, but a lot of it points to things that were developed in the private sector.
Yeah, that's really interesting. I think, some great sort of insights there to help people sort of navigate this policy area. Certainly me as an external non-policy wonk, I'm frustrated watching from the outside, but I feel like that's, valuable insights in terms of how maybe individuals, companies, and so forth can help push and change and move us towards this better infrastructure and goals. So moving forward, as you think about the Health Information Exchange Collaborative, obviously, a central tenet to that is interoperability. So that feeds in. So obviously, there's got to be some positive impact for the regulations that are now rolling out. But, there's some other things going on. Tell us a little bit about what's going on. You talked about 81. That's a lot of HIEs to be sort of participating. Does that mean that we've got 81 different groups that are truly sharing information that's accessible and people can plug into that?
It really varies. So SHIEC's coverage is 81 different HIEs across the country, across 45 states, so almost all the states. And HIEs really vary. It's true, you can say when you've seen one HIE, you've seen one HIE. However, you're seeing HIEs starting to really expand their work into all different kinds of use cases beyond just, clinical information exchange. They are working in the public health space. They're working in social determinants of health and community information exchange. They're working on things that are more in the population health analytics area. So you're really seeing HIEs that have good sustainability and good connections within their states, really expanding what they do. But at this point, it really takes all kinds. I think the most important thing to think about here is that, HIEs are generally the result of an investment that a state and a community of healthcare providers and payers and plans and other healthcare stakeholders have come together to create and work on for their community. And so just like we just talked about, it's really tempting to come in from the top and say, we need a national solution. But that's just not realistic on the ground. HIEs are different, and they're important because they represent the needs and the preferences of their local and regional stakeholders, who are generally multi-stakeholder coalitions of people who are affected by this, right? Including patients, including providers, including payers and plans, including all other, community representatives. So it's just really important to recognize that health information exchange is local as much as it is national. And so, I think when folks think about like what is a policy I can impose here to sort of make HIE happen, it's really tempting to say we're going to make everybody do this national thing, but that's not effective. What you want to do is make sure that information can be exchanged across jurisdictions and also to the federal government when necessary, but still representing and reflecting and respecting that sort of local and regional HIE investment and effort. And so they'll try to make it complicated. It's not that complicated. The federal government should support state and local efforts and also help build the national chassis and infrastructure and make sure that standards and technology are as standardized as possible so that we can really enable nationwide interoperability.
So I think, great progress in terms of connecting many of the dots, remains imperfect. But, for me, all of the lessons around incremental steps, don't let perfection stand in the way of progress, delivering value. And then COVID-19 happens. Could we turn to that and say HIEs potentially another possible silver lining outcome from the COVID-19 experience, do you think?
Yeah, I'm hesitant to say silver lining with anything involving COVID, but I do think that
we all are, to be clear.
Right? Would rather do without if I had a choice. But I think that in general, what you saw is that communities, whether they're states and communities, regions, any place that has really invested heavily in their HIE infrastructure, they were able to turn to those HIEs and start getting information quickly. So many HIEs started standing up things like bed trackers, ventilator trackers, started doing things to enhance the information that states had about patients with COVID, right? One of the things that HIEs tend to do really well is patient matching and sort of combining those longitudinal patient records from many different places. A patient shows up in a hospital with COVID, an ER with COVID, and suddenly they're able to access all of their records from various different places and understand their coexisting conditions. And I think that is really, really important in an area that they were able to step up quickly. And then it's moved on from there, right? They're assisting with things like immunization programs. They're connecting the immunization information systems. They're connecting and providing that missing information about health equity that you keep reading about, how people who are getting the vaccines aren't the people who are at the highest risk of dying from COVID. And so these are all places that HIEs are really playing, that are really expanding and, making sure that, that programs have the right information at the right time. So I think we saw where communities had invested in HIEs in a serious way, where there was real connectivity to the state and to public health and to Medicaid, they're able to collect on that and they're able to get information in a faster and better way. And that's just going to grow. Like I said, there's more and more connections coming out to immunization information systems that are being built up across the country. And, as that expands, I expect those HIEs to be even more involved.
So for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Lisa Bari. She is the interim CEO for the Strategic Health Information Exchange Collaborative, or SHIEC for short. What a cool branding idea that is, just going to say. We were just talking about the sort of value proposition that this has really delivered to states, regulators, all of these regional groups that have been struggling with information, and data is the driver, or at least it should be the driver of everything that we do in response to this pandemic. I think all the way back to sort of early days from beds, which shocking that we even had to sort of think about that, but that became a highly topical issue. Now moving into immunization programs and, trying to resolve some of the health equity issues that I think all add significant value. As you think about this going forward, we've got a new administration in. They clearly have a different take on the world, a different focus in healthcare. Tell us a little bit about where you see this going and what the opportunity is for further development, expansion of some of these capabilities, and how you're driving that.
Yeah, absolutely. So one of our big one of our big priorities at SHIEC, we primarily do work to make sure that lawmakers and regulators understand the role of HIEs in all types of health reform issues and all types of improving quality initiatives, advancing interoperability. All of those things are really important to us. So we do a lot of educating and trying to make sure that HIEs are not sort of left out of the discussion, because we fundamentally believe that if you have invested, millions and millions of dollars through the HITECH Act into building out these HIE use cases across the country in sort of state and federal partnership, you should not lose all that investment. You should make more of it. You should grow it. You should support it. You should make sure it's sustainable so that it can actually further those objectives. Okay, so with that in mind, we're looking at all of this COVID legislation, CARES Act, other legislation to provide COVID relief. And we want to make sure that some of those funds can go to further enhancing the HIE use cases that are already in place. So that's a big priority for us. And I think that will continue to be a priority with the Biden administration. One thing that I'm really interested in, which we'll see what they end up doing. Previously, when President Biden was running for office, he talked a lot about the public option, the so-called public option, which is an alternative to fully government-provided healthcare, but rather just an option for people to purchase on the healthcare.gov exchanges that would be provided by CMS, let's say, just like Medicare. And so you would just buy into the system, and they would compete against private commercial health insurers. And, this is a major policy lever if it's actually implemented. One of the things they could do is they could say, for the public option, in quotes, HIE, Health Information Exchange, is necessary. It's a requirement. If you are offering healthcare under this public option, we have to make sure that all of your health information is shared so we don't waste resources, so that we make sure your information gets to the right people, for example. They could also, for example, require that any healthcare delivered under the public option has to be, you have to make sure that everything is coded or inputted into an EHR in a certain way. They could require certain use of standards and technology they can't require from other payers yet. So there's all types of things they could do with that sort of policy vehicle, including, I think, promoting health information exchange. It could be very, very interesting. And so we don't know what they're going to do yet. They haven't really given us a lot of signals. But I think if they go down that path, we would certainly encourage, whether it's working with an HIE who's a member of SHIEC or not, that health information exchange, the verb, is a key and core part of any type of healthcare that's delivered by the federal government.
Yeah, it feels like, if we step down that path, rather than adding it as an afterthought, which, is
right.
The kind of things that we've done with some of the HITECH Act as an example, where let's implement all this stuff, but they don't need to talk to each other. Why would you need to sort of enforce any of that? Even the architects of those programs, lament the failure. So I think this is a great opportunity to sort of enable, a more thoughtful approach. Politics aside, I think to your original point of that critical mass, it feels like there's a sense of critical mass of an urgency, because so many people are sort of being displaced. And I think you're seeing, perhaps as a result of the HIE work that you've done, this inequity that's being shown through in the data that historically would have been unavailable were it not for all of the work that you've done.
Yeah, that's exactly right. And going back to sort of the creating a critical mass, you see in the CMS interoperability and patient access final rule, and the recent proposed rule on interoperability and provider burden and prior authorization, which, by the way, the future of that rule, which was pushed through at the very end of the Trump administration, is in question because the Biden administration has pulled back all of these rules that were finalized very recently. However, if you look at the provisions of that, they're really just continuing to build on the previous interoperability rule. And those rules, that rule and those rules, they really start to move us in that direction. They say, if you're a payer or a plan who is regulated by CMS, you have to share information, right? That's what these rules are asking for. They're saying you have to share electronic health information via a standards-based API. Great, that's wonderful. So that's, again, building the critical mass of saying, fundamentally, you have to share information in healthcare, and here's how we're going to get to it. This would be just another way of sort of continuing to build on that and saying the underpinnings of everything, the basis for everything is health information must be shared. We must achieve interoperability. We believe HIEs can help. SHIEC believes HIEs can help with actually making that a reality. But fundamentally, the idea is health information must be shared. Stop using excuses. Stop wasting money. Stop wasting time. We've got to enable that exchange one way or another. And so that's that's where I would see this going.
Yeah, and not just wasting of resources, but better care, because an awful lot of those wasted resources are in fact repetition of things that we didn't need to do. We just didn't have the available information. So I think there's a positive spin as in addition to the sort of, saving of money. This is better care. So,
and also I should say also patient time, right? I think, we talk a lot about provider burden, and certainly the most recent rule focused on provider burden, but, it really fundamentally harms patients when they are unable to access their information, which is, again, sort of the underpinning of 21st century cures and the thinking behind information blocking. And regulating that and requiring people to not information block. This all results in an incredible amount of time and effort on patients' behalf that is really often ignored by the healthcare community. But ultimately, we hope this results in patients being able to easily access their information in the form and format that they choose, especially if it's an electronic form and format. So, hopefully this also leads us to a future where patients don't struggle as much to get their full information.
So in the balance of the time left, I know this is a big question, but you intimated a little bit. You said that HIEs are good at patient matching. One of the reasons that we have to do patient matching is that we have no national patient identifier. Social security number aside, that isn't it. It's never meant to be. Do you see a pathway where either that's necessary, and if it's necessary, viable as a potential future?
Yeah, I mean, I'm not willing to sort of put my thumb on the scale either way from a sort of a universal patient identifier or not. But one thing I can tell you is that if there is a ban on even researching better options, we're in a dangerous place, right? Just like the fact that there was a ban for a long time, and it still sort of is, on funding for gun violence mitigation. Same thing. There should never be a ban on researching better solutions from Congress or anyone else. And so the only thing I can certainly say is that there should never be a ban on researching information about how to improve patient matching. I'm not willing to put my thumb on the scale yet on whether it needs to be a single patient identifier or just better tools. But I do know that when there's a ban, we have a problem. So we've got to find solutions. We got to find them faster. HIEs have great information in this space, and their expertise and years of experience should certainly be pulled upon by federal regulators and lawmakers to figure out the best solution.
I think that's extraordinarily pertinent. The idea that we ban research. I mean, unless it's unethical research, I mean, right. I get, but, for that principle, it just seems really strange to me. So I think
exactly.
Great point to close with. Unfortunately, as usual, we've run out of time. I think, fantastic conversation. I think tremendous opportunity for HIEs, both as a sort of inflection point, but also building on, capabilities that we've had. Just remains for me to thank you for joining me on the show, Lisa. It's been a pleasure.
Thanks so much. Likewise.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.